Kindly take over the chairperson.
Hello, can you hear me?
Yeah, yeah.
Yeah. I, along with my co-chairpersons, Dr. Singla and Dr. Gadikar, I welcome all of you for this afternoon. And we have got the three speakers with the so there is an international speaker. He is one of the authority on the subject. Dr. Amit, please.
So I would like to first of all thank the organizing committee of ISGCon Pune 2021 for asking me to talk to you today on Achalasia Cardia, how to select the most appropriate therapy. As all of us know, there are various subtypes of Achalasia Cardia as seen on HRM. Like, for example, you have type 1, type 2, and type 3, and its associated other spastic disorders of the esophagus. And over the last so many years, multiple treatment modalities have evolved for the treatment of Achalasia Cardia. And the oldest treatment modality is, of course, surgery, which is more than 100-year-old. And the next, which was described, was balloon dilatation around 40 years back, after which, around 20 years back, was injection of botulinum toxin in the lower esophageal sphincter. And the youngest treatment modality, which was described just more than 10 years back, was per oral endoscopic myotomy, or which is a type of a third space endoscopic procedure. If you were to see the surgical treatment of Achalasia Cardia, either in the form of open surgery or laparoscopic Heller's myotomy, has always been considered as the gold standard, and it has been shown to have a very effective control of dysphagia with some associated serious adverse events. That can be associated with mucosal perforation while performing the myotomy in anywhere between 1 to 10% of the patients, which is not truly considered as a complication by the surgeons. Of course, in some patients, you can have recurrence of dysphagia, and in spite of adding an associated fundoplication with the Heller's myotomy, some patients, for example, anywhere between 2 to 26% have been shown to develop GERD after the procedure. Rare complications can also occur. However, this was always considered as the final long-term treatment of Achalasia Cardia until the newer treatment modalities were evolved. It was 40 years back that a simpler treatment was invented, that was balloon dilation, which was predominantly being practiced by the medical gastroenterologists. An inherently simpler treatment where balloon is passed across the ADS and dilatation is done up to almost 35, sometimes up to 40. And by doing this balloon dilation, you could achieve an initial response anywhere between 70 to 90%. However, if you were to follow up these patients for 5 years, almost 50% of patients of balloon dilation could develop a recurrence of symptoms. And most importantly, if you see here, one third of these patients required repeated dilatation to maintain their recurrence of dysphagia. Another problem of balloon dilation was that because this is an uncontrolled tearing of the lower esophageal sphincter muscle fibers, you could get an unpredictable perforation rate anywhere between 0 to 21% and some minor issues like chest pain. But in spite of all this, balloon dilation has always been preferred as the primary modality of treatment by most of the medical gastroenterologists, where they could achieve a reasonably good short-term response and, if required, do a repeat dilatation after a few years. Comparing lap Heller's myotomy with balloon dilation, you can see here from this meta-analysis of randomized controlled trials and various studies that there is no doubt that even if the initial response may appear similar, lap Heller's myotomy is considered to be much superior to the pneumatic dilatation as far as the long-term response of dysphagia is concerned. And of course, the adverse events like perforation, which were much lower in lap Heller's myotomy as compared to balloon dilation. Post-operative GERD, there was no significant difference between the two. Around 20 years back, another simplistic form of treatment was evolved, again by Dr. Pasricha, it was in 1995, who showed that by injecting botulinum toxin into the lower esophageal sphincter, we could achieve a similar result like balloon dilation. And you can see here from this initial response can be anywhere between 70 to 90%. However, within a period of 6 months after Botox injection, almost 75% of these patients can develop a recurrence of symptoms. And in case you give a second injection of 100 units, we can achieve a remission for another one more year in 80% of these patients who have recurred. However, after the next second injection is given, subsequent injections have been shown to have a much lower response for the Botox injection. The most important advantage of Botox injection is it is not associated with any serious adverse events. Some rare adverse events have been reported like mediastinitis, sinus formation, etc. The youngest treatment modality to be evolved is, of course, the peroral endoscopic myotomy, which was invented or described 12 years back by Professor Inoue from Japan. And over the last 12 years, there have been more than 700 publications on POEM procedure and probably more than 20,000 POEM procedures performed all over the world. So POEM, as all of you know, is basically performed in these 4 steps, where initially you do a submucosal cushion by injecting some diluted saline containing some contrast agent, blue contrast agent, and then an incision is made in the mucosa. Dissection is done of the submucosal tunnel, and then the tunnel is extended till the OG junction and a few centimeters beyond it, after which a myotomy is performed depending upon the subtype of achalasia. You can see either we can do a full thickness or a partial thickness myotomy. And then once the myotomy is done, all that we have to do is to close the mucosal incision with a series of clips. And these patients do extremely well. If you see the clinical results of POEM as published in 2016 from the systematic review and meta-analysis on 36 studies, a POEM is an excellent procedure because it causes a significant reduction in the LES pressures, IRP, height of time barium. However, there can be an associated GERD with the POEM, and you can see from this meta-analysis that symptomatic GERD was reported in around 8.5%. Actual endoscopically shown esophagitis in 13%, but abnormal acid exposure on pH metry studies was shown in patients which are nearly almost 50% of the times. And in fact, you can see here, POEM also has been compared with laparoscopic Heller's myotomy in this systematic review and meta-analysis, where 4 databases were studied. And here you can see that almost similar number, 196 POEM procedures, 290 lap Heller's myotomy procedures. There was no significant difference between the 2 procedures as far as reduction in Eckhart score, operative time, post-operative pain, analgesic use, and complications. But the symptomatic GERD was significantly higher in the POEM procedure as compared to the lap Heller's myotomy, and the hospital stay, of course, in the POEM was shown to be significantly lower. If you were to see the POEM versus laparoscopic Heller's myotomy, recently 2019, a multi-center randomized trial was published comparing the 2 procedures, because POEM was being practiced all over the world now as an alternative to lap Heller's myotomy. So therefore, this trial was conducted. And if you can see from this trial, overall, the initial clinical success of the POEM was not much different from the lap Heller's myotomy. Even the serious adverse events in POEM was lesser than the lap Heller's myotomy. But if you see the 2 months and the 24 months incidence of reflux esophagitis, it was significantly higher in the POEM procedure. So the conclusion of this randomized control trial was that the POEM is not inferior to the lap Heller's myotomy at DOR, but reflux esophagitis is significantly higher in the POEM procedure. So therefore, in spite of POEM being such an inherently nice technique, being easily performed by many gastroenterologists, and a very good alternative to laparoscopic surgery, it was in 2017 that an editorial was published in Endoscopy by the editor, Professor Thomas Roche, who had written that editorial naming it, "Is Reflux Going to Kill POEM?" Now, exactly for this reason, to counter the so-called side effect of POEM of GERD, in 2018, the inventor of POEM, Professor Inoue, started, and he described this procedure where in the same procedure of POEM itself, he could perform an endoscopic fundoplication procedure. where what he actually showed was that you could do an anterior myotomy, go across the lower esophageal sphincter, and then go anteriorly further, cross all the layers of the esophagus, and then cut the visceral peritoneum and enter inside the peritoneum. And once in the peritoneum, you could turn to the left, see the left lobe of the liver, and see the anterior wall of the stomach, the fundus, and actually fix the fundus by means of loop and clip method, and then also fix this loop to the cut edge of the muscle. So this is a procedure which he performed and calling it the POEM-F procedure. And this is how that procedure is performed, where you can see that we are doing an anterior myotomy first, we are doing a fluid cushion, and then we do the dissection. And after reaching the lower esophageal sphincter and going beyond it, then we start cutting the tissues beyond the muscle, inside those fibers in the lower, in the subphrenic fat pad. We start dissecting the fat pad, and then thereby we reach the visceral peritoneum. And then after cutting the visceral peritoneum like this, we can pass the scope inside the peritoneum. And once we have gone inside the peritoneum, we can actually see the left lobe of the liver anteriorly, the stomach, which is there down. And then we catch hold of the stomach like this by means of a clip, along with which a loop is attached. So loop is attached to the anterior wall of the stomach on the fundus, and by a series of clips, and then the scope is pulled back, and that same loop is also attached to the cut edge of the muscle fiber inside the tunnel itself. And once this is done, that endo loop is closed, and by this, what actually happens is the fundus gets pulled inside the tunnel, and thereby we can achieve a sort of a fundoplication. If you were to see that after performing this procedure, how does it appear? The endoscopic appearance almost looks as if you have done a laparoscopic door fundoplication. Well, this did make a big impact, and some endoscopy centers, some endoscopists in the world started practicing this procedure routinely. They started performing in all patients an anterior myotomy, go inside, use an anterior approach, and include a fundoplication procedure with a loop and clip technique. In fact, you can see here that in 2020, a paper was published by Amol Bape's group from the Dinanath Mangeshkar Hospital, where they showed that is POEM-F going to be the answer to the post-POEM GERD with a single session endoscopic fundoplication in 25 patients. In a retrospective analysis of prospectively collected data, they showed that the technical success was very good. Median follow-up was 1 month, 1 year, and they could find an intact wrap in a majority of the patients, in 80% of the patients at the end of 1 year, with a abnormal acid exposure in around 11% in these patients. However, we also conducted a study and was published around the same time, but our results were a little bit different in 20 patients where we performed the POEM with fundoplication. Similar retrospective analysis of prospectively collected data, technical success was good. But we found that in follow-up, in 1 month itself, we found loosening of this wrap in almost 30%, whereas in almost 40% of the patients, the wrap had loosened at the end of 3 months. And if you see here at the end of 3 months, the abnormal acid exposure had almost reached what would be in a patient where you have not done any fundoplication procedure, which is almost 40%. So therefore, we started wondering whether this endo loop and clip technique is really going to be durable. Because if you were to go to see the results of even a surgically constructed fundoplication, these patients are known to have a recurrence over the period of years, and therefore fundoplication which is done only by loop and clip technique is unlikely to be durable. So our conclusion was, even though this is technically feasible with reasonable short-term success, the durability, early success, and safety of POEM needs reassessment in long-term studies before being routinely applied in clinical practice. Recognizing this drawback of with endoscopic fundoplication using the endo loop and clip technique, Inoue very recently in 2020 described a case series in Video GI where instead of using a endo loop with clip application and doing a fundoplication, he did an anterior approach, performed an anterior myotomy, went outside in the peritoneum, and instead of putting the loop, he actually sutured it by using this special suture, because the special type of a flexible needle holder type of a device was invented in Japan. It is now available in the prototype stage. And with this, even though this is a preliminary experience, that can be one of the ways by which we could avoid this so-called problem of peroral endoscopic myotomy of post-procedure GERD by performing a fundoplication endoscopically in the procedure itself. Well, if you ask me personally, then the ideal approach would be to perform the POEM procedure in the normal fashion by the anterior or the posterior by the method. And in only those patients who develop post-procedure abnormal acid exposure, we can advocate an endoscopic full thickness plication by using a special device like this, which is a EFTP device, which is called as the GERD device. You see here one such patient who's undergone a POEM in the past, who had abnormal acid exposure. And here we are performing the GERD procedure. So this GERD procedure is quite simple to do. So in a U-turn, you can open the arms of this GERD, and then by pulling the full thickness layers of the lower esophageal sphincter inside the two arms, we can apply staples. 1, 2, or 3 staples can be applied either on the greater curvature side or on the lesser curvature side. And with this, if you will see the end of this procedure, it also appears as if we have done an extremely good reconstruction of the lower esophageal sphincter. So instead of applying a POEM with fundoplication in all the patients and doing an anterior myotomy and going in the peritoneum, this can be a via media, where if these patients do develop a GERD or abnormal exposure after POEM procedure, they can be subjected to the EFTP procedure or the GERD procedure. So therefore, what is the ideal treatment for Achalasia Cardia? If I were to choose between injection, dilatation, POEM, or surgery, what I feel is the treatment should be universally applicable. It should be safe with minimum adverse events. It should be easy to perform and reproducible, minimally invasive, not too expensive, good short-term effect, and of course, a sustained long-term effect. So therefore, to conclude, I would like to state that one should understand that we should never have a dogmatic approach, but have a very rational approach as far as Achalasia Cardia is concerned. Because after all, what we are going to do is not treat the actual pathology or pathophysiology, but we are going to only treat the symptoms of dysphagia and select the patients accordingly. Well, for type 1 and type 2 patients, in the short term, pneumatic dilatation, laparoscopic Hiller's myotomy, and POEM are all efficacious. However, we should explain to the patient very clearly all the pros and cons of the procedure, the intensity of the procedure, the so-called long-term effects, the possibility of adverse events like perforations, and then let the patient select the procedure. One thing is for sure, that the problem of GERD after POEM procedure, the patient should be told that if the patient does have GERD after the POEM procedure, we can always offer them an endoscopic full thickness plication if they are found to have an abnormal acid exposure. As far as type 3 is concerned, surgeons have been advocating that they can also do a lap Hiller's myotomy. However, POEM is shown to have an inherently higher success for type 3 and other spastic disorders. The most important reason being that during the POEM procedure, the endoscopist can access almost the entire length of the esophageal body, and therefore we can do a long cut, which is not possible all the time by doing a surgical procedure. In patients who are extremely high risk, elderly, or those with severe comorbidities, botulinum toxin injection still continues to remain as the treatment of choice, because it has got the least possible side effects and the patient can tide over the problem of dysphagia. Thank you for your attention.
Yeah, Dr. Amit, excellent presentation as usual. So we have in a unique situation of pregnancy with the Achalasia Cardia. So what should be the ideal treatment?
Pregnancy, I don't think it comes in the way, because you can straight away go ahead and do a POEM procedure. In case the patient can tolerate insufflation, can tolerate anesthesia, I don't think it's an issue, because we can definitely go ahead and do a POEM procedure. The only problem is pregnancy itself can lead to GERD. So after the POEM procedure, we have to do a lot of dietary modifications for the mother, and make sure that the diet is proper, and possibly give some local antacid therapy instead of giving PPIs. And with that, we can tide over the problem. But POEM can be performed in pregnancy.
So is it safe to use indigo carmine and the methylene blue during the pregnancy?
It doesn't matter, because this is not going to get absorbed. It is going to be only for local staining of tissues. We will use very, very minimum amount of indigo carbine.
Okay.
It is just a sky blue color. We don't have to make it dark blue. It doesn't matter.
And sometimes patient with Achalasia Cardia, they have extensive submucosal fibrosis, and the lifting becomes very difficult. So any special suggestion or instruction in that scenario?
See, that is an ideal case where you should not even attempt a POEM procedure. I mean, if you want to, you can first initially try in giving some fluid in the submucosa, and if you find that lifting is not there, don't attempt a POEM procedure. You can actually see the mucosa and take a decision. And if that is the case, you can place either a nasogastric or a nasojejunal tube, wait for 4 to 6 weeks without any oral feeds and only feed them through the tube. In majority of these patients, their mucosa completely recovers. And then you can recheck the mucosa and then decide the POEM procedure.
So
Yeah,
any
because
role
of short
self-
of time, I will request the chairperson to start the next lecture.
So the next lecture is again very interesting. It's regarding complication of POEM. Will be delivered by Dr. Jahir Nabi, who is an excellent endoscopist. Over to Dr. Jahir.
Good afternoon. I'm Dr. Zahir from AIG Hyderabad. I thank Team ISGCon Pune for providing me with this opportunity to speak on this platform. The task given to me is to speak regarding the complications of POEM, management and prevention. The definition of adverse events related to endoscopic procedures was standardized almost a decade back by a group led by Peter Cotton, and this definition still holds valid for almost all the endoscopic related complications. The most widely utilized classification system is ASG lexicon to classify and grade adverse events related to endoscopic procedures. But with respect to third space and endoscopy procedures and POEM, the problem is the set of complications is unique, and this classification system relies to a great extent on the number of days spent in hospital due to that complication. So it may not be an ideal classification system to define adverse events associated with POEM. Similarly, Clevin-Dindo classification system was thought to be better for POEM or other third space endoscopy related procedures. Actually, this classification system was proposed almost 2 decades back for surgery related complications. So again, this classification system is not specifically designed for defining adverse events related to third space endoscopy. So this is high time to standardize the reporting of adverse events associated with POEM or other third space endoscopy related procedures. In an attempt to uniformly classify and standardize adverse events associated with POEM, we made an attempt and we defined adverse events according to the timing of adverse events as well as the severity of adverse events. So adverse events can be defined according to the timing, that is before the procedure, during the procedure, after the procedure, and late after the procedure, and that is specific to peroral endoscopic myotomy, that is gastroesophageal reflux. So what is the incidence of major adverse events associated with POEM? That depends on the classification system you use. For example, if you use ASG lexicon, the adverse event is 0.5%. If you use a modified classification system, the rate of major adverse event may be as high as 3.3%. Coming to the prevention and management of some of the commonly related adverse events associated with POEM. So to begin with, the first is insufflation related events or gas related events that we commonly say them. And the majority of these events are in fact not adverse events because they don't require any specific intervention. These may be capnoperitoneum, retroperitoneal CO2, capnothorax, and rarely capnopericardium. If they require some minor intervention like drainage procedure, these may be classified as minor adverse events. In case they are associated with some major problem like hemodynamic compromise or abortion procedure, they may be classified as major adverse events. How to deal with the gas-related events? The first is to identify, that is, you see if the patient has significant abdominal distension and the anesthetist raises an alarm that the end-tidal CO2 is high, the peak inspiratory pressure is high. What you do is you pause the procedure, you take the scope out of the tunnel, go into the stomach and deflate the stomach if it is too much insufflated. And the next, what you do is you adjust the ventilator settings and your anesthetist will help you in that. You increase minute ventilation so that it expels the CO2 out of the body. And finally, drainage is pretty straightforward. In cases of capnoperitoneum, you put a needle, 16 or 18 gauge needle in just below the right costal margin, and this is a fairly simple procedure to do. In case you don't find capnoperitoneum, but still the patient has significant abdominal distension and the entitled CO2 is high, peak inspiratory pressure is high, in most of these instances, retroperitoneal CO2 is the cause. In these cases, just pause the procedure for a few minutes. CO2 absorbs very rapidly as compared to air, and after that, you can restart your procedure and complete it. The prevention of gas-related adverse events, some of the strategies are well proven, like always using CO2 for insufflation. You try and use a low flow or extra low flow gas tube, and positive pressure ventilation has been shown to reduce gas-related adverse events. You can also choose to voluntarily restrict insufflating, keep on insufflating while you are doing tunneling or myotomy. Try and avoid long procedures, and in that for that, you can avoid long myotomies which are not required for type 1 and 2 achalasia. A wide tunnel and an adequate mucosal incision will also help CO2 to escape from the mucosal incision. So this is the data from our initial study where we compared low flow and extra low flow gas tube and showed that use of extra low flow gas tube helps in reducing the development of gas-related adverse events. Coming to mucosal injuries, which may be immediate or delayed, and these mucosal injuries may be classified according to their thickness. There is partial thickness or full thickness, or these may be classified according to the ease of closure, which the Chinese have proposed. Type 1 injuries are relatively straightforward and easy to close, whereas type 2 injuries are difficult to close and you may require special closure techniques. The predisposing factors for mucosal injuries, the excess coagulation near mucosa, in my view, is the most common predisposing factor. And if this mechanism of injury is especially common if the mucosa and muscle are close, like at gastroesophageal junction, where most of the mucosal injuries occur. In cases with severe submucosal fibrosis, where mucosa and muscle are adherent, and use of excess coagulation may lead to mucosal injury as well. In cases with challenging anatomy, like advanced sigmoid achalasia and those with esophageal diverticulum, you may accidentally lose the path and reach towards the mucosa and cause a mucosal injury. The other mechanism of mucosal injury, when you don't clear the mucosal incision adequately and force your scope inside the tunnel. In that case, what happens is the mucosal incision enlarges, which you don't want. And this is especially common if you are doing an anterior poem where the angulation of scope is much more as compared to posterior poem. So this is one of the case where we were doing anterior poem and the mucosal incision enlarged because the mucosa was unhealthy and the mucosal incision was not adequately cleared. So it's very important when you say that how to prevent mucosal injuries, the judicious use of electrocautery is very important. And some of the minor bleeds can be ignored. For example, this bleed along the mucosal side, successful hemostasis was achieved and a successful mucosal injury was also achieved. So always use your electrocautery very judiciously. And the reason why I say so is the coagulation currents that we use for dissection, like tunneling and myotomy during poem, they work at very high voltages, and higher is the voltage and higher is the proportion of thermal burn that is produced. So be cautious when you are using these modes, because these modes are very powerful and work at very high voltages. The other techniques to prevent mucosal injuries, whenever you are dealing with advanced sigmoid, always remember that you have to go perpendicular to circular muscle fibers. That is one way to avoid losing your path. And the second is use a guide wire technique. If you lose your path and you're not able to find the direction of the tunnel, then you can choose to use fluoroscopy, place a guide wire into the stomach, see the guide wire under fluoroscopy vision, and reorient your scope accordingly. In cases with severe submucosal fibrosis, the first is always minimize the use of excess coagulation, because mucosa and muscle are adherent. For example, in this case, what we found that along posterior side, there is severe submucosal fibrosis. Water jet sign is present, which is almost a definite indicator of severe submucosal fibrosis. There is no lift. The beauty of POEM is that you can always change your orientation or change the site of injection. And this way, you can achieve a good submucosal bulge and proceed with POEM successfully. For example, in this case, posterior side, we could not get a good lift, but along anterior side, we got a good lift. There was good submucosal bulge, and the submucosal tissue was also generous, and we could successfully complete the procedure. How to close these defects? I think majority of the defects can be successfully closed using through the scope clips. There are other modalities as well, like over the scope clip, endosuturing, and stents. The use of stent is usually not practiced, but this may be especially useful in cases where there is a large area of thermal burn or thermal injury and the mucosa is very unhealthy. In those cases, clips and sutures won't hold, and these stents may provide a rescue treatment strategy. Which clip to choose? It's a very important question. I think in expert's hand, all clips behave nicely, but when you are beginning POEM procedures and if the mucosa is not healthy, it's very thick, then you can choose one of the clips which is of reopening type and which has a good closure strength. So always remember that not all the clips are equal. Some clips, they grip better than other clips. So you can choose these criteria to, in special cases, you can choose a different clip than your routine clips. How to close these injuries? The first principle is do no harm, and often these thermal injuries which occur during POEM, they have devitalized mucosa, and when you try to close these defects, on the contrary, you may end up in enlarging these defects. So always remember that you have to engulf the mucosa which is not devitalized, which is not discolored, and choose a wide area so that you don't end up in enlarging that mucosal defect. In some cases where the defect is large, you may choose to use a loop and clip technique. This is a very handy technique, a very useful technique to close the larger defects. Coming to delayed mucosal barrier failures, this is not very common, but in achalasia, the mucosa is not healthy, and sometimes the mucosal injuries are not apparent at the time of POEM, and these patients may present after a few days with the delayed mucosal injuries and delayed mucosal barrier failures. So the predisposing factors are more or less the same: an unhealthy esophageal mucosa, excess use of coagulation, and sometimes when we choose to ignore these thermal burns, which may later convert to full thickness injuries. So how to diagnose them? Contrast study or barium esophagogram, they are not very sensitive and they have been criticized. They often miss these delayed mucosal barrier failures. So therefore now some experts are choosing a second look endoscopy in selected cases to identify these delayed mucosal barrier failures, especially if you have a doubt that the mucosal incision or the previous mucosal injury may not have been sufficiently closed. You can choose to do a relook endoscopy before you start initiate oral feeding. So these are some of the cases in my experience wherein I encountered delayed mucosal barrier failure. The first case, as you see here, was a case where the incision site, we applied excess coagulation due to bleed at incision site, and this led to this delayed thermal burn. Similarly, second and third case, where you can see that these are classical examples of delayed mucosal injuries. The good part is that the mediastinum usually seals off and the contrast usually does not leak into mediastinum. The contrast at the most leaks into the tunnel, but does not go beyond into the mediastinum. So it's fortunate that majority of these can be managed conservatively. Just place in nasogastric or nasojejunal tube, leave them in situ for a few days, and the patient are going to do just fine. Delayed bleeding, which is not very common and very tricky to manage. the presentation is usually during first 3 weeks, and the classical presentation is chest pain, bleed, either hematomasis or melena. Some patients may present with dysphagia due to submucosal hematoma, and the patients may have postural symptoms as well. The classical endoscopy finding if the patient presents early in the course is submucosal hematoma. Some patients, if they present late, the clot tries to come out through the esophageal mucosa, so you may find a esophageal mucosal defect and a clot coming out through that defect. So this is one of our cases where we encountered delayed bleeding. The CT showed submucosal hematoma, and when we did an endoscopy, there was a defect at lower end of esophagus, the lower end of the tunnel, and a clot was coming out of that tunnel. So how to prevent these delayed bleeds? I think we should apply the principles of endoscopic submucosal dissection here as well. We can choose to preemptively coagulate the visible vessels. And the reason why I'm saying this is because some of these vessels may be partially injured while you're doing submucosal tunneling or myotomy, and partially injured vessels may not be readily apparent endoscopically on vision, and later these may bleed. The management includes and it takes into consideration whether the patient is having hemodynamic derangement and evidence of active ongoing bleed. If there is hemodynamic derangement, you have to do endoscopy, you have to do some procedure because the bleed is ongoing and massive, and this has to be controlled. If there is no hemodynamic derangement, there is no evidence of active ongoing bleed, you just wait and watch, and majority of these patients will come out with flying colors. So this is one of the cases where we encountered delayed bleed, and we can see that the blood is oozing from the region of close to GE junction. The clips have to be removed so that you can gain entry into the tunnel. After gaining entry to the tunnel, use various accessories like rock mat or snare to remove the clots. Finally, you localize the site of bleed and use your hemostatic forceps to achieve hemostasis. What should not be done is always avoid the use of Sangstogen Blakemore tube. Although it has been described, but I feel there's a huge risk of mucosal tear, and there's no muscle layer behind, so it does not allow tamponade. The balloon has no support of muscle layer so that it can provide tamponade. And moreover, even if you insufflate the balloons, there's no guarantee of hemostasis. The bleeding may continue into mediastinum or peritoneum even after inflating the balloons. So this is the last aspect of my talk, poem and gastroesophageal reflux, a burning topic for last couple of years. What we know as of now is the incidence of reflux esophagitis and pH positive GERD, it ranges from 40 to 60% after poem. Fortunately, the symptoms are less common, and usually not more than 1/3 of the patients are symptomatic as a result of GERD. But what is very reassuring is that GERD is mild after poem. Majority of patients have grade A or B esophagitis, and almost all of them, they respond to proton pump inhibitor therapy. So another reassuring finding in recent studies is that the incidence of reflux after poem reduces with time. As years pass by, the incidence of reflux in fact reduces. And the major reason proposed for that is that the G junction remodels, and the cross-sectional area reduces, the compliance reduces, and that is one of the reasons that the esophageal acid exposure also reduces with time after poem. In contrast, if you see GERD after Heller's and fundoplication, it in fact increases with time due to loosening of that fundoplication wrap. We also have a couple of potential strategies that may reduce reflux after poem, and these include preservation of sling fibers during posterior poem. And second is nose fundoplication, and I think Dr. Bapai has published a nice recent study where he has shown that the wrap may stay intact for a year or so. But in my opinion, this technique is still not ready for prime time, and we need a more robust technique to create fundoplication wrap. I'll end my talk by raising a query that what we are measuring in PS studies in patients with achalasia, is it reflux or is it fermentation related acid? So this is something which has generated a lot of controversy, and some of the recent papers say that actually we have to be very cautious in interpreting the results of PS studies, because many of these patients actually don't have reflux. What we measure is actually acid produced as a result of fermentation, which is due to stasis. To summarize, this is the summary slide, which shows whatever management and prevention strategies I have discussed in the previous slide. I think majority of the adverse events can be managed endoscopically or conservatively. So you don't need to worry for major adverse events associated with doing procedures, because majority of them can be handled. That's all from my.
Thank you, Zahir. That was a very elegant talk. For want of time, we are cutting down the question and answers. We will directly start with the next lecture, which is to be delivered.
Good afternoon, friends. Thank you, IIG Scientific Committee, for this kind invitation, variants of poem. We all know